I think that we can start. Good morning.
This is Paulina Godzisz.
Together with Weronika Kwiatkowska, I will lead today's session. I am honored to greet you at the Internal Medicine session of International Medical Students Conference in Krakow. Polish Society of Internal Medicine have accepted the patronage of our session. This is the 23rd edition of the Krakow Conference, during which medical students from around the world present their medical academic achievements. We have abstracts from 5 countries: India, Serbia, Ukraine, Belarus, and Poland. In today's session, we have qualified 8 oral presentations and 7 posters. Unfortunately, not everybody could come, and only 7 oral presentations and 3 presented. Works will be evaluated by a 5-member panel composed of Professor Aneta Undas, Maciej Małecki, Jarczewska. Before we proceed with today's presented works, I would like to communicate a few organizational items. Time of presenting the oral report cannot exceed 7 minutes. Screen will display a timer which will signal the end of a time. Unfortunately, in case of excessive extension, we'll have to stop your presentation. So I kindly request the speakers to pay attention to a time. A discussion is provided after each presentation. However, it should not be longer than 3 minutes. And here I kindly ask the evaluation panel to pay attention to a time as much as possible. 4 minutes are provided for the presentation of the posters and 2 minutes for the discussions. There will be 2 breaks during the session. First, 5 minutes after delivering oral reports, and second, 10 minutes after the end of poster session, during which the evaluation panel's deliberations will take place. The official language of the conference is English. The work should be prepared and presented.
So, even though we know that leukotrienes are pro-inflammatory mediators, and we know that they participate in every phase of atherogenesis, unfortunately, so far we don't know their role in post-PTA complications in the long-term follow-up. And that is why today I would like to focus on promise from each director to provide 2 additional awards, so there will be altogether 7 prizes or awards. And that will be somehow acknowledge all of them.
Okay. Prizes are awarded together for both oral and poster presentations. Rating of a scientific committee is final and unquestionable. And now I would like to introduce you to listen to the reports.
Our first presentation will be leukotrienes, new markers of restenosis after percutaneous transluminal angioplasty in lower limb ischemia. I kindly invite Mr. Mikołaj Maga to present.
Thank you very much. Dear professors, dear colleagues, good morning, everyone. My name is Mikołaj Maga, and I'm honored to attention. Altogether, 33% suffered from diabetes mellitus. Most of them, it was, of course, diabetes mellitus type 2. Coronary disease was college. And today I would like to ask a question: if leukotrienes can be a new marker of restenosis. They used to smoke, and 30% say that yes, they are still smoking, but we have to know that these data are not very objective. So what was our algorithm? After the successful PTA, we took the urine samples from our patients. First was just before procedure, and 1 day after procedure. Of course, we also filled a questionnaire which consisted of information about other illnesses in the past, family history, and other important for us data. The patients were leaving our ward, they were going homes, happy that everything is okay, and we asked them to come for follow-up meetings, which took place 1 month, 3, 6 months after the procedure. During every follow-up, all of the patients were measured for the ABI. Also, the urine samples for the leukotrienes level were collected, and all the patients went through the clinical review, which was carried out by doctors. So what all of them had to be after 6 and 7 month follow-up, which is not very uncommon. And there are only 2 patients who had restenosis within first month after the procedure. When we take a look in patients who are 5 and 6 in Rutherford scale, but unfortunately they have unhealing wounds, so leukotrienes are as a pro-inflammatory markers can be used in those group of patients. So we enrolled 179 patients. Most of them were male, and 2/3 were with Rutherford 3, and 1/3 was with Rutherford 4. Almost 3/4 suffered from hypertension. You can see that patients. We checked if the level is only a marker, which we already know, but if can be also a predictor. And note that patients who had the restenosis in 3rd month follow-up had also increased level in the 1st month follow-up. To conclude my short presentation, I would like to say that from this study we know that we took the urine samples from our patients. First was just before procedure, then it was just after procedure, and 1 day after procedure, predictor of restenosis in next months. And there is no influence of rise pro-operative leukotrienes level on follow-up prognosis. Thank you for your presentation. I hope that I took your attention, and I will be able to answer your questions. Thank you very much.
Thank you very much for your presentation. Now is 3 minutes for discussion and questions, please.
6 and 12 months after the procedure, during every follow-up, all of the patients were measured for the ABI. Also, the urine samples for the leukotrienes level were collected, and all the patients went through the clinical review, some out by doctors. So what were our results? As you can see on this chart, most of the restenosis occurred between 6 and 7 month follow-up, which is not very uncommon. And there are only 2 patients who had restenosis within first month after the procedure. Spectroscopy carried out in a laboratory on Skawinska Street.
Very nice and interesting study on a large group. The question is, does kidney dysfunction affect levels of leukotrienes that you measure, and have you controlled it for that?
Yes, we checked, but the dysfunction of renal was present in a group of patients who had rest stenosis, and it didn't differ between those two groups. And we also did not observe any increase of the leukotrienes in those specific subgroups of patients. That is why I did not present it in here. We also measured many other factors, but we have very short time, so I focus on those who has, in our opinion, real impact.
Thank you very much. Are there any more questions from the audience? I encourage students to ask. Okay, if this is not the case, I have one question and one comment. You said that you tested LT predictor of rest stenosis. So my question is, what kind of statistical test did you do? Was this regression analysis? In the case, what kind of variables did you include into the model?
We have to know that every patient has a little bit different level of leukotrienes in their body. There is no norm of leukotrienes in this case. So we have to look, answer your questions. Thank you very much.
Thank you very much for your presentation. Now is 3 minutes for discussion and questions, please.
Interesting presentation. Which leukotrienes did you measure and how?
Comment, because I think that we are here also to learn something. In the first point of your conclusion, you wrote increased level of LTs in urine correlates with the occurrence. In fact, you didn't use a formal correlation test, so I would probably say that level of LTS in urine is associated. It's more safe. It is more general than sort of using correlate word.
Very nice and interesting study on a large group. The question is, does kidney dysfunction, renal dysfunction affect of trends that you measure, and have you controlled it for that?
Yes, we checked, but the dysfunction of renal was present in a group of patients who had rest stenosis and who didn't have, and it didn't differ between those two groups. And we also did not observe any increase of the leukotrienes in those specific subgroups of patients. That is why I did not present it in here. We also measured many other factors, but we have very little time, so I focus only on those who has, in our opinion, real impact.
Thank you very much. Are there any more questions from the audience? I encourage students to ask. Okay, if this is not the case, I have one question, and tested LT as a predictor of rest stenosis. So my question is, what kind of statistical test did you do? What is regression analysis? And if this is the case, what kind of variables did you include into the model?
We have to know that every patient has a little bit level of leukotrienes in their body. There is no norm of leukotrienes in this case. So we have to look on the peaks of leukotrienes, and we focus on this. But if you are asking me about the name of the test, I'm sorry, I can't answer this question because it's not my specialization. So I'm deeply sorry, but I can't answer this question, but I can answer it via email when I will check accurate information.
Okay, and one more comment, because I think that we are here also
to assess proportion T-student test and Mann-Whitney U test as appropriate to assess the continuous variables and univariate and multivariate logistic regression to determine the possible predictors of dehydration in terminal cancer patient. On admission, 43% of patients were diagnosed with dehydration. They were less frequently in family care and less frequently received glucocorticosteroids prior the admission. They more frequently suffer from nausea and vomiting on admission and had higher risk of neuropsychiatric symptoms, weight loss over 30%, and dyselectrolytemia. Dehydrated patient had a higher level of total and ionized calcium and higher level of sodium and lower of level of potassium, but these results were not statistically significant. On multivariate logistic regression, after adjustment for possible confounders, lack of family care and no prior opioid use were independently associated with dehydration in terminal cancer patients. In conclude, lack of family care and lack of opioid use in terminal cancer patients are risk factor for dehydration, and patients with dehydration are more likely to develop weight loss and psychiatric symptoms during hospitalization. Thank you for your attention.
Congratulations, a very nice presentation. I'm wondering whether you observe any differences related to the sex or to the type of cancer.
We don't see this because this was not statistically important.
Maybe not important, but power of the study was too low to assess this difference, I think.
Any more questions from the experts, from the students? Professor Gusik.
You performed retrospective analysis. You sort of deliberate what is the disadvantage of this type of analysis in respect to question that you've asked, and what would be the most ideal design.
So we use the history of the patient, developed family and caregivers. So we could not be able to examine this patient and
would there be a way to sort of, because many studies are done based on records, what would be the way to sort of make it more reliable, still basing on the history and on records? Increasing number help.
Thank you very much. And any more questions? If this is not the case, I have to. Okay. Again, I will repeat that we are here learn something. Okay. So your major outcome was dehydration, right? So maybe I have omitted this, but you need to define how you have diagnosed dehydration. So we do this.
So we take this this one from history. So there was a sign dehydration on this, and we're not able to know how the caregivers took this information.
Okay, so the presence of such diagnosis in the medical documentation.
Yeah.
Okay. And the other question and comment related to the statistical analysis, you have included some information. You performed logistic regression analysis. So to give a full picture of the analysis that you have done, it's important to provide the entire list of variables that was initially included into the analysis. Can you say how many variables were sort of initially taken?
I'm not able to.
Okay, and usually when you perform multiple logistic analysis, it consisted of two parts, univariate and multivariate, as you said. So usually it is done by stepwise logistic analysis. So those who are significant in the first step are taken to the second step, multivariate analysis. I think that in general, to provide the full picture of the job, it is important to include this. But again, very nice presentation, and the information concerning statistics were included. Okay. Any more questions? If this is not the case, let's applaud the presenter. And the next one.
Okay, next we would like to welcome Ms. Agnieszka Waxman for her first presentation called The Screening Study on the Influence of Population in the Place of Living and Smoking Cigarettes on the Level of Carbon Monoxide in Exhaled Air.
Good morning, dear professors, dear students. My name is Agnieszka Waxman. I'm a fifth-year student at Jagiellonian University Medical College, and I'm going to present a work which is the screening study on the influence size of population in the place of living on the level of carbon monoxide in exhaled air in groups of non-smokers and smokers. Presentation. Thank you. First of all, I would like to introduce this. Then I will talk about the purposes, methods, and results. And at the end, I will try to conclude everything. The poor quality of air is one of the most important reasons for increased CO level in exhaled air. It is caused mostly by enlarging car traffic and industrial activity. The knowledge about the higher pollution in big cities, and it's bigger than in small cities and villages, and its influence of place of living and CO level in exhaled air has not been well studied yet. The increasing number of respiratory diseases is a very important problem of our times. The issue is being noticed by many famous journals and magazines. For example, last edition of The Guardian called Krakow second most polluted city in the world, in Europe, excuse me. The aim of the study was to check the influence of place of living on the level of carbon monoxide in exhaled air compared in the population of cigarette smokers and non-smokers. Last year, I was standing here in front of the jury presenting our trial study. Opinions. We cooperated with IFMSA Poland during the project Health Under Control. We conducted a multi-centered study in Krakow, Warsaw, and in Kozienice. We asked our patients a questionnaire which concerned many data. The personal data, the data about the smoking cigarettes in the place of living. Also, we asked our patients to sign the consent on the study. And of course, here are the results of the examination. We examined the level of carbon monoxide with a tool called Pico Smokealyzer tool. And to be sure that every single result can be placed, so we can be sure. Statistic was based on generalized linear models with logit link for a binary response with interaction between explanatory data. We made a t-test to compare our results. And we recruited 505 patients, 201 male and 304 females. And the average age of our patients was 39 years old. We divided our patients into 4 groups. First is the small towns, the people who are living in small towns. For us, small town is a town under 500,000 citizens, and also we included the villages there. And the big towns, which is the towns over 500,000 citizens. And then we divided the groups into two subgroups of cigarette smokers and non-smokers. As you can see, the average result of CO level in a population of smokers differs according to place of living. They were much bigger in big towns than in small towns. The whole results were statistically significant. The difference more expressed. As you can see here, the average result of CO level in a group of citizens of small towns is really low, and in a big towns is even exceeding, which is 4 ppm. We all know that cigarette smokers had a greater chance to have an increased CO level in their exhaled air. But we checked, we created a model with a multiple logistic regression analysis that, according to the baseline, the non-smokers are living in who are living in small cities. There's when you are a non-smoker who are living in a big city, there's a 15 times more chance to have an exceed CO level over the normal range, which is over 4 ppm. And whole model was, of course, statistically significant. To continue, living in a small town, the median of level of CO doesn't exceed normal range, which is 4 ppm, and it's significantly lower than the populations living in the big cities. Results shows us also that not only smoking cigarettes has influence on the CO level in exhaled air, but also the place of living and the quality of air does. Smoking cigarettes is connected with increasing the level of CO in exhaled air over 4 ppm. The percentage of smokers in both groups, in both cities, small and big, are very similar. And we want to carry on more of this. Next weekend, we have another health under control in Bonarka City Center, which I ask kind to you. Oh, okay, never mind. Sorry. And at the moment, we also still waiting for the data from Wojewódzki Inspektorat Ochrony Środowiska that will help us to improve our research. Okay, thank you for the presentation, for your attention, and if there are any questions.
Thank you. A really very nice talk. I'm wondering whether could you address the issue of passive smoking in your study?
Thank you for the question. Unfortunately, we didn't measure the passive smoking cigarettes. We only focused on the active ones. Can we, thank you? Yeah, here. We only asking our patients if they are smoking, not if they're like passive smokers. So.
And what about the characteristics of a group of patients? Did you have any inclusion criteria or something?
Yeah, we asked our patients if they're they have diabetes or hypertension, but the whole 4 groups were similar, so we didn't include this data into our research.
Very nice topic and very nice presentation. But did you ask them about COPD and asthma?
No, we didn't ask them about this diseases, but we want to improve our research and we want to put more questions in our questionnaire.
Would be interesting. So, if I understand correctly, how do you recruit the patients? Could you describe this briefly? The subjects, yes, in a way.
We have a project called Health Under Control, and it's in IFMC Poland, and it's in some kind of shopping malls, for example, or at the universities. And the people are coming to us, and they are filling all the questionnaire. And then we are measuring with the breathe in, hold an air about 15 seconds, and then blow out the whole air which was in the lungs into the tool.
And last, very brief question. Did you ask these people where do they work? Because some people spend more time at work than at home.
Yeah, this was a place of living, the place where they are staying, it was the proper question. So where they are spending the greater amount of time.
Any more questions from the audience? From students? Yes.
All the study was based on the questionnaire, what we can see. Can you tell us, when you analyzed the results, did you blind it somehow?
The whole study was blinded because we divided our questionnaire into two parts. The first one was just the data, the personal data, and the second one was examination results. For example, yeah, SEO level is here. And we created some kind of code that it's connected with a place where the examination was taken and an ID number of each patient. And we divided them under the whole recruiting process. And for example, in here, the card from Krakow, we putting into the databases this part and we sending this part to Warsaw. So we can kind of blind our tests.
Any more? Yeah.
Yes, everything was analyzed, and we our results are, even if you smoked 1 cigarette per day in the continuous time, but even if you smoked a package a day half year ago, put it all information into the databases, and if you were a smoker, if you smoked in the past, it still counts like you were a smoker.
I have 2 questions. Students' contribution. What did you do? Did you do the actual examination?
Yes, we did everything here.
Okay, good. Good to know. And you took a cutoff point of 4 ppm. What was this based on from the literature?
We based on we found some kind of studies, maybe not the same subject, but about also the SEO, and there was a cutting point of 4, and also our member of the team who was making all of the statistics also has noticed that there's a line from 4 above to distinct
Okay, so you took this from the literature, from sort of similar studies. And the last question, you said that your multiple logistic regression model was significant. Very good. And you said that in this model there were both place of living and smoking status. But what were the actual predictors? Both of them, places of living and smoking status, or one of them, because there must have been some significant predictors.
As I said, on the beginning of the, can I just? As I said, there's a level. So we decided to put a non-smoking group together and analyzing if difference between the citizen of a small and a big city. But we also compared everything to 4 groups to each other, because we have 4 groups, A, B, C, D.
Yes.
Yeah. And we compared the groups to each other.
Okay, thank you very much.
Thank you.
Okay, I think that we should applaud the presenter and move to the next presentation.
I would like to call up Ms. Sylvia Bartizel, and she will be presenting the frequency of complications during fiber optic bronchoscopy.
Ladies and gentlemen, dear colleagues, my name is Sylvia Bartizel and I represent the student scientific group at the second department of internal medicine of the Jagiellonian University in Krakow. I would like to present to you the paper titled "Frequency of Complications During Fiber Optic Bronchoscopy." Fiber optic bronchoscopy is a common diagnostic tool used to evaluate patients with various respiratory. In current medical practice, there is much controversy as how to perform the ideal bronchoscopy. For a procedure so important, there are several components are yet to be defined, like ideal drugs, ideal doses of those drugs, patient perception of bronchoscopy, tolerance of the procedure as an invasive one, or how we, as a medical staff, can reduce patients' anxiety and symptoms. The main aim of our study, this particular study, was to compare the complications that arose in patients following fiber optic bronchoscopy for the first time in their life and for another time in their life. This particular prospective study included 463 patients to our department from August 2013 to June 2014. They were divided into two groups. 268 patients who underwent the bronchoscopy for the first time in their life were compared with 195 who had this procedure before. A person chi-squared test and 2x2 contingency tables were used for statistical analysis. Each of those patients were administered lidocaine, fentanyl, and midazolam. Additional doses of those drugs were given to patients as they needed during the procedure. To gain a good understanding of their satisfaction, patients were asked to complete a detailed questionnaire detailing their experience. They were asked if they had developed any symptoms after and during fiber optic bronchoscopy, what they remember from the procedure, their comfort level, waiting time, and their satisfaction with the medical staff. Amongst our patients, 60% feared the procedure. The most common causes were pain, 30% of the patients, dyspnea, another 29% of the patients, severe cough, 26% of the patients, and 21% of the patients. However, there are some significant differences between both groups. Please notice that patients who underwent bronchoscopy for another time in their life were less afraid of pain, cough, and disease, and the risk of anesthesia were causes of anxiety regardless the number of procedures that the patient had previously undergone. Complications during the procedure were cough, 29.8% of the patients. Other complications observed during the fiber optic bronchoscopy were hyperactivity, apnea, hypotension, and bradycardia. Please notice that there were no significant differences between both groups. There were no differences between people who had this procedure first time or another time. Adverse also occurred with similar frequency. The most common are cough, pain, and hematoptysis, and only nausea occurred more frequently in the patients who underwent the bronchoscopy for the first time in their life. Complications like dyspnea, headaches, fevers, or shivering were not statistically significant also. Nonetheless, it was found that 87% of patients reported that the use of anesthesia improved their satisfaction with the fiber optic bronchoscopy. However, additionally, 89% of them would agree to undergo another procedure in the future. To conclude, to summarize my presentation, the most common complications during fiber optic bronchoscopy were severe cough, hyperactivity, hematoptysis, and pain were most frequent adverse symptoms after bronchoscopy. And the frequent complications and symptoms related to bronchoscopy is similar for all patients, regardless the number of the procedure that the patient had previously undergone, and their complications influence the patient satisfaction. So it's very important for us as a medical staff to prevent them during and after bronchoscopy. Thank you for your attention, and I would like to invite you to a discussion.
The most important issue, could you present us some data on your patients, comorbidities, age?
So the average age of our patients were about 60 years. Of course, they were common because of the age and specific of department where our patients were not exactly healthy. Usually, there were patients with lung tumor or COPD or asthma. Of course, about 70% of them suffered from hypertension. And the other most common disease was smalllitis, usually type 2.
Okay, thank you. Did you observe any associations between these diseases and complications you just reported?
It's known that experience of operator, of a person performing procedure, is an important factor. Where procedures performed by similar, the same operators in both groups, and were there any associations between complications and, for example, experience of a person performing procedure?
I am able to on the first part of this question. I know that there was 2 doctors who performed those bronchoscopy, but we did not we did not in our questionnaires ask. The questionnaire that we gave was 3 parts. One of them, the middle one, accepting the procedure as well, was to the doctor and to the medical staff that was in the room during the bronchoscopy. And we did not ask about their feeling during the bronchoscopy.
Any more questions? If this is not the case, I will return to the comment of Professor Undas, because as I said, it is important that we learn something. And I think that we, as the expert, would like to emphasize that in this kind of studies, when you are comparing certain outcomes, for example, side effects, patient's reaction, it is important to present the initial clinical characteristics in order to see whether they differed in terms of some variables, characteristics, because they could have the impact on the outcomes. And my question, what was your students' contribution? What did you do in this study?
We couldn't, of course, perform the bronchoscopy as we are students only, but we talked to the patients before and 2 to 4 hours after the procedure because of the using of midazolam and fentanyl. So the patients were not always full conscious, full mental ability short time after. So we checked the questionnaires and as well. But we also, in part, examined the patients ourselves.
And where did you take the questionnaire from? Did you design it, or
Yes.
it was something from the literature?
No, we designed this questionnaires based on existing literature.
Questions? Professor?
You mentioned that you gave questionnaires to the patient and to the doctors. I was wondering if there was a full concomitance of sort of did the answers agreed if you asked about the presence of certain symptoms between how patient reported it, how staff reported it.
Of questionnaires given to the medical staff were well, we asked the medical staff were asked about side effects during the procedure based on some definition that we developed during the study. And afterwards, when we given the questionnaires to patients, there were their subjective observations, how they feel about the procedure and parts.
Did you validate the questionnaire?
Well, we discussed this questionnaire with our tutors, with President Wojciech Szeklik and with professors at our department.
Okay, thank you.
Let's applaud the presenter. Thank you very much.
Thank you.
Our next presentation is Mr. Kamil Polak with his presentation called Assessment of Perioperative High-Sensitive Troponin T Measurement, Prognostic Value and 30-Day Follow-Up. Here you go.
Good morning, ladies and gentlemen. My name is Kamil Polak, and I'm a member of scientific group of Second Department of Internal Medicine. And I would like to present you the results of our study concerning prognostic value of high sensitivity troponin measurement, prognostic value in 30-day follow-up in patients undergoing non-cardiac surgeries. To fully understand the importance of our project, we need to be aware of a scale of this problem. Every year around the world, more than 200 million adults undergo cardiac surgeries. Despite the improvement in perioperative care, the mortality rate remains at a stable level of 1 to 2%, which results of deaths of 2 to 4 million people every year due to complications associated with these surgeries. The most common complications are associated with cardiovascular system, and they are especially challenging for the clinicians due to their silent clinical nature and presentation and limited utility of standard tests like echo and ECG. The preliminary results of VISION study showed that even 84% of such events would not be detected if not for troponin monitoring. So the aim of high sensitivity troponin T measurement, prognostic value in 30-day follow-up in patients undergoing non-cardiac surgeries. Our scientific group participated in a large international study, VISION, performed in cooperation with McMaster University in Canada under the supervision of Professor P.J. Devereaux, and the preliminary results have already been published, for instance, in JAMA and Anesthesiology. Our study group consisted of 901 patients at the age of 45 years or more, undergoing vascular surgeries. 5 blood samples were taken from before the operation and 4 post-operatively. And then 30 days and 1 year after the procedure, follow-ups were completed by phone. High sensitivity troponin T levels were measured in each of blood samples. Each of the patients has been very precisely described in terms of comorbidities, hospitalization, and surgery course, administrations associated with surgery. And at this point, I would like to put emphasis on differences between our study and the previous part of VISION. They have used generation troponin T, which is not high sensitive, and they haven't measured the preoperative level. We have used 5th generation T. We have measured it both pre and post operatively, and our data have not been published yet. Our study group consisted of patients undergoing vascular surgeries, which are regarded as surgeries associated with high risk of cardiovascular events. Moreover, advanced age had history of smoking and multiple concomitant diseases, which resulted in a group of patients with high risk of cardiovascular complications. In our analysis, we have used 2 cutoff levels with 14 nanograms per liter, as it was used in the VISION study protocol, and higher, 54 nanograms per liter, as it is used in currently ongoing studies. When we have analyzed the higher cutoff level, it's turned out that both preoperative and post-operative elevation above cutoff level were significantly associated. Were significantly higher. Elevated high sensitivity troponin T levels were significantly associated with higher mortality in 30-day follow-up. Interestingly, when we have analyzed the lower cutoff level, the results were similar. It also turned out that preoperative and post-operative elevations above cutoff level associated with significantly higher mortality in 30-day follow-up. Moreover, patients who died had significant troponin T levels in all measurements, both pre and post-operative, than survivors, of course. And to sum up, I would like to say that even small elevations in both pre and post-operative high sensitivity troponin T levels were associated with higher mortality in a 30-day follow-up in patients undergoing non-cardiac surgeries. What's more, non-survivors had significantly higher AGST and T levels than survivors, both pre and post-operatively. We strongly believe that AGST and T monitoring gives an additional information about patients' risk of death, and it could be a very useful tool for clinicians dealing with perioperative care on a daily basis. It may also improve detection of clinically significant myocardial injuries, thus improving patient outcomes. On the other hand, there are also some doubts about this kind of monitoring. The exact impact of comorbidities on AGST and T levels has not been precisely described yet. And it is feared that AGST and T is too sensitive, and its implementation to standard perioperative assessment may result in increase of frequency of discoveries by anesthesiologists. However, we strongly believe that such monitoring would let us better understand perioperative myocardial injuries and will let us reduce the mortality in patients undergoing non-cardiac surgeries.
Hi. Like in the previous case, the patient characteristics are lacking, and we agree that comorbidities data interpretation. Yeah. Could you be more specific and tell us, for instance, how many patients experience in the past myocardial infarction or other thromboembolic events like stroke, another issue, how many of them had renal failure or such data, which are very important, really.
Yeah, this data is of course very important, but this project is based on a quite limited database at the moment. We have finished the full data like 2 weeks ago. And we have counted that almost all of the patients had peripheral vascular disease, and I think that almost 80% had hypertension, and around half of the exact data have not been counted yet.
And the question that this study brings to me refers to an editorial in JAC written a few years ago by a person involved in troponins as such, who said that, as far as I remember, well, when troponin was a lousy test, have you read this? It was a lousy test, it was a great marker. But now when it is, when we have a great test, it is a lousy marker. It could indicate that actually it may be a lousy marker for myocardial infarction because it's being very criticized when it's extremely high sensitivity, but it could be sensitive for other uses. But your study brings a very important question, whether what you observe is related to perioperative mortality, whether it's related to the surgery that this patient underwent, or whether it's a predictor of mortality in general population. Do you have any comment whether it's just a predictor of mortality in me and you and all of us sitting here? Maybe not all of us, because some of us have less atherosclerosis than others.
It's very hard to say, and I think that the better answer to this question will be given by my presentation, who will more concentrate on the diagnostic value of troponin T. He will concentrate on the fact that it's necessary to observe the dynamics of troponin T levels.
Exactly. So have you looked at dynamics of
in this study? I have concentrated only on the association between troponin T levels and mortality of the patients.
Any more questions? So maybe a routine question: what was your contribution, your students?
That's a big topic to talk about. It's an effect of 5 years of work of our scientific group. Over 60 students have participated in this study, and we have done almost everything. I came to the scientific group 2 years ago, so I'm not the person who did the most of the job. Some of the students are already residents in Krakow hospitals. We have done almost everything. We have qualified to do the study. We have talked with them before before operations. We have filled the CRF's contact report forms, and we have sent them to Canada. We have filled the database. We have completed the follow-ups. I think that's an amazing job by over 60 students, more than 60 students.
Okay, I will add also a similar comment that was already said, that you need to look at TND in the context of other variables, risk factor, to truly test whether this is an independent predictor of the event. And you wrote here in this last slide that it could possibly increase in frequency of disqualification from surgeries by anesthesiologists. I would rather think about, I would say, special attention here, rather than, a disqualification from the procedures that are, necessary to treat or to treat the patient, sometimes to save one's life.
Yeah, but it's interesting because when a vision study supervisors decided to measure preoperative troponin, they didn't agree to do that because the anesthesiologists were afraid that they will receive a little bit elevated troponin level, like 15 nanograms per liter, which they don't think it's really clinically significant, and they would be afraid to qualify such patient to surgery, because if anything happened after the surgery, somebody could accuse them of qualifying patient who had already elevated high sensitivity troponin T level before the surgery. So around the world.
Very interesting comment. Okay, thanks a lot. Good answer. Any more questions? If this is not the case, let's applaud the presenter. And the next oral presentation, right?
Will be by Mr. Jakub Frontek with his report called The Influence of Chronic Diseases on Preoperative High Sensitivity Troponin T Levels in Patients Undergoing Non-Cardiac Surgeries. Just before he begins, if I could have your patience, I'd like to fix this timer very quickly. Sorry. Is it all right if I time you? Sorry, is it all right if I time you here, or would you like the timer displayed? Can you? Yeah? Sorry about this. There we go. Now just set it for 7. Here you go.
Thank you very much. I believe my presentation is the last one in the oral session, so we can start looking forward to coffee break. Thank you for a kind introduction, ladies and gentlemen. My name is Franczek. I'm glad to be with you. And I also represent the scientific group from Second Internal Medicine Department, which Kamil also. And today I would like to share with you the results of our study concerning the influence of chronic diseases on preoperative high sensitivity to non-cardiac surgeries. So I believe it's a kind of continuation of what Kamil said. If anyone wonders, this is a troponin staining in cardiomyocytes. So, as my colleague said, about the topic of it's a huge problem. As we can see in this slide, presenting the main causes of death in the United States, the number of deaths after surgery is vast and puts them on a high 3rd place. Over 200 million non-cardiac surgeries are performed each year around the world, and they are associated with a substantial complication rate. And most of these complications are cardiovascular. So, preliminary results of vision studies suggest that we should introduce a new clinical diagnosis named MINS, which stands for myocardial injury after non-cardiac surgery. How is myocardial injury different from myocardial infarction? The main difference is clinical presentation. What they both have in common is being a serious threat to the patient. So, MINS is based on peak troponin T elevation to 30 nanograms per liter after exclusion of ischemic causes of such elevation. Vision study was carried out using 4th generation troponin. However, in our study, we used more sensitive 5th generation, as Kamil said, and those levels cannot be directly compared. And occurs in about 8% of the operated patients. Its diagnosis is especially challenging because of its silent clinical presentation and limited usefulness of standard tests like electrocardiography and echocardiography. Already mentioned Professor Devereux and co-workers showed that without perioperative troponin measurement, most of myocardial injury cases would have been under. Moreover, they proved significant influence of MINS occurrence on patients' outcomes, with mortality comparable to myocardial infarction, which would mean that 1 in 10 patients who get MINS will die. Aforementioned facts clearly indicate the usefulness of perioperative troponin levels. And however, the current MINS diagnosis isn't definitive yet, and probably will change in time due to the development of more specific biomarkers and further insight into myocardial injuries. We hypothesized that interpretation of an elevated troponin non-cardiac surgery could have been greatly enhanced by preoperative measurement, giving clinicians better understanding of patient's condition. The aim of our study was to examine the impact of morbidities on preoperative high-sensitivity troponin levels in patients after undergoing non-cardiac surgeries. Our research group consisted of 231 patients, and they were in advanced. Most of them suffered from multiple chronic diseases. Almost all our patients had peripheral vascular disease. 3/4 of them had hypertension, and half of them suffered from coronary artery disease. So we've also evaluated patients with chronic obstructive pulmonary disease, congestive heart failure, patients who had a stroke in the past, and patients with atrial fibrillation. All of our patients underwent vascular high-risk surgeries, which in combination with their chronic illnesses significantly increased risk for adverse cardiovascular events. We obtained 5 blood samples for troponin measurement, one before and 4 after this presentation. This is the most important one. Our results show that 36% of patients had troponin above 40 nanograms per liter. We've demonstrated that troponin levels are significantly elevated in patients who suffer from hypertension, coronary artery disease, chronic obstructive pulmonary disease, patients with stroke, diabetes, congestive heart failure, and patients who have atrial fibrillation. So, our analysis suggests that in an aging society where multiple chronic diseases could an individualized patient assessment. I'd like to cite a study by Nagler and others, who stated elevated preoperative troponin leads to worsened outcomes, increasing risk of further troponin elevation threefold, myocardial injury, myocardial infarction risk, almost long-term survival. It's our firm belief that the dynamics of troponin elevation can be more reliable than just the peak troponin level itself. We've tried to highlight that preoperative measurement could be used as a benchmark in the diagnostic process, giving clinicians a useful tool for assessing the patient. I would like to cite one more study by Nato and others who advocate that patients who have a change in troponin levels after surgery are in even more dangerous situation than patients with a stable elevated level. And I would like to show you a brief clinical example. Let's look at a patient with hypertension, coronary artery disease, and chronic obstructive pulmonary disease with a postoperative troponin level of 55 nanograms per liter. So without preoperative troponin, the clinician faces a dilemma, being aware of patient's comorbidities. Should he diagnose means myocardial injury after non-cardiac surgery and potentially modify his treatment and the diagnostic route? What if we had measured the preoperative troponin? Now we can look our probability in these two cases because this patient has no significant rise in troponin level. However, this one has a value 8 times higher than at the beginning. So we have to wonder what happened. So this leads to the conclusion that preoperative troponin measurement should be implemented as a part of high-risk patients' assessment. And finally, awareness of myocardial injuries brings an urgent need for prevention methods and treatment. Aspirin and statins may improve patients' outcomes, however, that needs further investigation, and there are currently other ongoing studies testing drugs in this therapy, which also would bring promising results in the near future. I would like to thank you very much for your attention. Invite a discussion.
Were your definitions of diseases solely based on medical records?
In the vision study, which I joined recently, so I'm not as experienced as Kamil, but from my knowledge, patients were precisely described using the vision study regulations. So the history was taken in correlation with those forms. The history taken by vision investigators, as Kamil said, students contributed to the study. We've precisely described the patients before the surgery.
For instance, about diabetes, yeah? Did you measure glycemia and...
Yes, it was measured before procedure also.
Renal function. Did you measure?
So this is a group of 231 patients, and as far as I'm concerned, only 2 patients had any renal problem here, so we couldn't evaluate that. They had a good general filtration rate above 30 milliliters.
Okay, thank you.
One of your conclusions is related to dynamics, but I might have missed it somehow. So do you have a real result that shows the dynamics of troponin is important for prediction? Because this is the conclusion you draw. Could you go back? Or?
Of course, yes, of course. I believe it's here.
The conclusion is dynamics, and do you have results showing that dynamics of
Okay, so
high and the peak level, because I'm not.
I'll try to answer as good as I can. But the dynamics, I mean, change in
Oh yes, this I
dropping the-
understand. I just want to know how you came to that conclusion, because conclusion is to be based on
and no,
engagement.
I understand. I think that's the question that I try to highlight in the last slide, and throughout my presentation, I try to give you an thing that means myocardial injury isn't a well-described clinical unit, and patients at a stable level, and it was written on the contact report form that there was no significant rise in drop points, so no other further tests were done because nothing changed. And
the question is, the problem here is a little bit, what will you do if we know before the surgery, as your colleague has discussed before, that the patient is 53 nanograms per liter? Does anesthesiologist go on like normal or not? I mean, the warning still persists, even though it occurs earlier. You don't show us the results of dynamics yet. It will be investigated in future.
Yes, they will be shown, and we try to, excuse me, to highlight this fact that such increase may change the clinical route with the patient, because there are studies that prove we have to intensify the treatment if we get such elevation in dropping. Myocardial injuries could be prevented, and if we act quickly, some studies say about a 24-hour time frame where we should intensify the treatment and maybe prevent the poor prognosis, which I have shown from other studies, increasing.
In the patient that went from 7 to 55.
There are studies saying about standard route for acute coronary. There are also studies with the dabigatran treatment, and those statements about aspirin and statins. This is also the preliminary result, and this is our what we predict to be good. However, we have to go to exact therapies. We have to have guidelines. I would like to highlight in my presentation that means is important, and we should look at it in the future.
Any more questions? Yeah, there is a comment from the back. Do you need a microphone?
I would like to answer Professor Enda's question. We have diagnosed patients' comorbidities according to their medical records, and on the basis of questionnaire, each of the patient that there was a ball with each patient. But if patient, for example, said that he had sudden cardiac arrest and we haven't found it in medical record, we have decided that it wasn't, and that in fact he had not had such event, because sometimes patients mistake, for example, cardiac arrest with myocardial infarction. The main information source for us was medical records of the patients.
Thank you, Kamil.
Any more questions? So I'm assuming that the answer to the question of your contribution to this particular research would be the same as previously.
Not in such extent, I would say. However, when I joined Vision Study, I've started filling the database, which Kamil said about. Now we have a full database of 1,000 patients, fully DTs with glycemia, with renal function, and those results have been published. We are still on our way to other publications.
Can we go back to the conclusion slide?
Of course.
Okay. As I said, we are here to learn something, to improve something. This is our role as we perceive this, the experts. So I think that the proportion of this of each part is a little bit I would say, could be a subject of debate, of dispute in your case, because I think that the introduction part was simply too large. It consumed you almost the half of your presentation. And if with the topic, with the title that you presented, you actually had only one slide for that. And I think it's...
Yes, I agree. When I also felt this, but I couldn't help myself mentioning means and describing because it seems very important to me, and the comorbidities results are just preliminary.
Fine. And in the context of results, as I said, you presented just one slide associated with them, with a specific title. So I think that you could have gone further, for example, showing the effect of self-esteem comorbidities, not only one by one, but two or three, whether, for example, having three comorbidities would have more impact than having one. Okay, this would be a suggestion.
Thank you.
And the last suggestion, essentially, only conclusion out of these 3 points that is truly associated with the specific original data would be the first one. The other two are sort of unrelated to the data that you showed. For example, and it should be remembered that this kind of, I would say, observational studies would not provide a definite answer concerning the usefulness of TNT as a biomarker in the clinical practice. You would need an interventional study to show that by using this marker and introducing progressive measures or treatment would improve the patient's prognosis.
Can I have a comment?
Yes, sure. That's why we are here.
I've checked it, the guidelines, the recent guidelines state that in high-risk patients, we shall also measure to be guideline, the preoperative drop point.
Okay, and Professor Guzik.
Just at the end, because your studies come both from the previous study and this study from Vision, right? And what is the relationship? Because your population is slightly similar than or smaller than the other one. Are these the same patients or are these different patient groups than the previous study?
It is 231 patients because up to the time when we were writing this study, we have just filled the database for 231 patients because it has been happening in recent months. So now it's 1,000. All of our patients are in the database.
It's one study.
Yes, those are now when we have a bigger group, we'll use better models. We'll check comorbidities in regression models and check. This is a pilot study. I would say this is a pilot study for the next studies.
Okay, I think that we need to move. Okay, so
I would like to only add that thanks to the Vision study results, that the new studies are beginning at the moment. For example, managed study, which concerns treatment of MINS. And the diagnosis of MINS in this study is also operative. And the cutoff level that I use in my work, the 54, is currently used in MANAGE. And in MANAGE, they are going to use dabigatran as a treatment method, potential treatment method for MINS.
And so again, thank you very much. Let's applaud the presenter.
Thank you.
Thank
I'm
you.
sorry I took so much attention and time of the jury.
And let's move forward. The last one, okay, the last oral presentation.
Okay, we have one last presentation before the break, and it's again Ms. Agnieszka Waxman with the influence of MAS and BMI on renal transplant in a one-year post-transplantation observation.
Good morning again. I already introduced myself, so I will just talk about the study. The study is the influence of mass and BMI on renal transplant in 1 year post-transplantation observation. We conducted our retrospective study at the Department of Neurology at Jagiellonian University Medical College, and these are just first results of our study. Of course, first I will introduce the subject, I will talk about the purposes, methods, and results, and at the end I will conclude. We all know that there's a negative influence of obesity on the renal function. Excess of leptin as well as hyperinsulinism contribute to it. Additional immunosuppressive treatment, which occurs during the post-transplantation treatment. Steroids and calcineurin inhibitors, especially tacrolimus, can deepen insulin resistance and glucose intolerance associated with it. The aim of our study was an attempt to assess weight and BMI's influence on transplanted kidneys' distant secretion function, which was evaluated with estimated EGFR. We recruited 140 patients, 52 women and 88 men in age of around 47 years old. All of the patients were in the stage 5 chronic kidney disease, and they undergo a kidney transplant during the years 2012 and 2013. We estimated the EGFR with MDRD formula, and we checked 4 measurements. It was just after the transplant, 1, 3, and 6 and 12 months. It was a retrospective study. And these are our first results from the study. There was a significant weight and BMI increase between 3 and 12 months after transplant. Also, in 1 year observation, together with the improvement of renal secretion function, creatinine concentration decrease and EGFR increase. Also, statistically significant positive correlations between body mass and creatinine concentration throughout the whole observation period has been observed, and we saw statistically significant negative correlations between the body mass, BMI, and EGFR in the 1, 3, 6 months post-transplantation. These are the results also, but in a more picture way in the charts. I would like to comment on the concentration on dots here, because when doctors measured the EGFR, if the renal function was all right, they just put it the number over 60. And we didn't want to create the numbers from ourselves. We just assume that the higher number is 60 and that the renal function here is okay. To conclude, the statistically significant inverse correlation between the body mass and BMI and EGFR has been confirmed, and also transplanted kidney secretion function stabilizes after 12 months after transplantation. Yeah, thank you for your attention.
Congratulations for a nice talk and a nice design of your presentations. Really, we appreciate. Yeah, and my comment is, are you aware of any limitations related to the use of the MDRD formula to assess renal function? The good formula, MDRD, you use it.
Yeah, we just
we
just use the data from the charts of patients. We didn't MDRD formula by ourselves. We just
only one formula.
Yes.
Mm-hmm. Okay, thank you.
Any more questions? Okay, statistically significant inverse correlation between BMI and GFR. Okay. That's correct conclusion. Any more comments? So what was your contribution, students?
Yeah, the study just started a few months ago, and we students just going to the place where all history charts have been stored, and we are putting out all the charts and putting all the numbers from the follow-ups to the databases, so we can just try to figure it out how everything is working. But we have also one problem. There are many patients who were transplanted not in Krakow, but in Gdańsk, in Wrocław, in Katowice, and there were missing some data from the first the transplantation period. So that's why our study is not full of data.
You wrote transplanted kidney secretion function. What do you mean by secretion function?
Yeah, it's for us it was GFR.
It could be rather excretion. Secretion, we mean erythropoietin, right? Hormones.
Okay.
What would
So
you say?
sorry.
Okay. Any more questions? Professor Gush.
Was there any relationship between the links between BMI and BMI changes and EGFR, depending on initial parameters, clinical parameters, or on similar treatment regimens, immunosuppression, and so on?
Yes. The first question was about. Excuse me, but I.
Whether the sort of BMI was affecting this, because people with very low BMI would have immediately sort of worse prognosis.
Yes, there was no such a correlation, such a thing. We didn't saw anything like this. And the second question about the.
It was about immunosuppression.
Immunosuppression, yes. Every patient underwent the same immunosuppressive treatment, the tacrolimus, the inhibitors of calcineurin. Yeah.
Thank you.
There's no more questions. So let's read that there will be some housekeeping announcements now, right?
Yes. Thank you very much, everyone, for your great deliveries and great reports. We will have a 5-minute break right now, and after which we will do the poster presentations, of which there are 4. And this time.
What I did is like I usually